Welcome back to my channel. Today I have come up with another new topic of pharmacology, that is antiemetic drug. So usually the question which is asked from these topics are drug for the morning sickness, drug for the motion sickness, drug for the chemotherapy or radiotherapy induced nausea and vomiting, and drug for the post-operative nausea and vomiting. And sometimes you may get a short note on antiemetic drug. So I'm Dr. Meenakshi Gupta from a conceptual pharmacology channel. If you like my video, please do subscribe and put up in a comment section any suggestion from your side. So let's get started with the topic antiemetic drug. So before going to the drug part, let's see about the pathophysiology of the emesis. So what is vomiting? It is involuntarily forceful expulsion of the stomach content through the mouth. So how this thing happens? This happens because of the stimulation of the important center, that is here it is a vomiting center which is present in the medulla oblongata. Once this gets stimulated, the person gets the vomiting. Now how this center it gets stimulated, there are many important pathways by which this center it gets stimulated. So one of the important thing is like motion sickness. That is very common thing which most of the people they experience, and the cause of that motion sickness that lies within the inner ear. So in the inner ear there is one bony structure, that is labyrinth. Within that there is many area, and the most important is that is a vestibule, and this is the area which is going to maintain the balance of the person, and this gets stimulated when the equilibrium is disturbed or when the person gets rotated. Then what happens? The impulses they travel from the vestibule to the vestibular nuclei. So this is a vestibular nuclei, and through which nerve? To the eighth nerve, as vestibulocochlear nerve. So once this is stimulated, it is going to stimulate the CTZ center, that is chemoreceptor trigger zone, and this ultimately is going to stimulate the vomiting center. Now another important cause is like this. This is number one. So another important is CTZ, that is chemoreceptor trigger zone. Now what is that chemoreceptor trigger zone? This is present in the area postrema, in the floor of the fourth ventricle. So this is the area which is not protected by the blood-brain barrier. So it comes in contact with many things, many like GIT irritant, poisons, then even cytotoxic drug. So all these they are going to stimulate this CTZ center here, right? So this center it is further going to stimulate this vomiting center, and this initiate the vomiting reflex. Another important cause of vomiting is many time we hear like people they say if they see something, if they see this blood or if they smell something bad, so they vomit. So that's quite common. And if the recall of any obnoxious event or if they are emotionally overwhelmed, then they vomit. The cause is simple. This all these things they are going to process it, all this will be processed by the higher center, and this is going to stimulate this vomiting center, and person vomits. And even pain also. What happens during the pain? Pain it is going to cause the release of the substance P and bradykinin. These two things they are released with the pain, and this is going to stimulate the neurokinin receptor, NK1 receptor, and this is going to initiate the vomiting. So another important cause of vomiting, that is in the stomach. Here it is our mouth. From the mouth, this esophagus. Esophagus is the one which is going to connect this mouth and stomach. Within the mouth there is a mucosal lining. I'll just zoom it. This is a zoomed view of this, right? ENS that stand for the enteric nervous system. Just like in the body we read about the sympathetic nervous system, parasympathetic nervous system. In the stomach there's some semi-autonomous nervous system, that is enteric nervous system, right? So if I zoom this part, you can see here in the stomach there are pits and glands, and various cells they are there. Out of that, one cell that is called EC cell, that is enterochromophene cell. Now, what is the importance of this cells? When this GIT, it comes in contact with any GIT irritant, any cytotoxic drug, with a radiation therapy or toxins or poisons, then what happens? This cell, it gets stimulated and it is going to cause the release of 5-HT in the circulation, right? Now, this 5-HT, it is going to further stimulate the extrinsic enteric nervous system and intrinsic enteric nervous system. This is through the extrinsic primary afferent neuron. It is going to carry the impulses to the nucleus tractus solitarius, and which is further going to stimulate the vomiting center. Even 5-HT, which spills into the circulation, it can directly on the CTZ center, the 5-HT3 receptor they are there, so it is going to directly stimulate the CTZ center, and once this is stimulated, it is going to stimulate the vomiting center. This is another way. Now this 5-HT in the intrinsic primary afferent neuron, here I haven't drawn the intrinsic primary afferent neuron, so it further makes a connection with the interneurons, that is excitatory and inhibitory. This I stands for inhibitory and E stands for excitatory enteric nervous system neuron. So this 5-HT, it is going to stimulate this excitatory enteric nervous system through 5-HT4 and going to cause the release of ACH, that is acetylcholine, whereas through 5-HT3 it is going to stimulate the inhibitory enteric nervous system and causing the release of NO, right? So with the excitatory enteric nervous system and release of acetylcholine, it is going to cause the contraction of the proximal gut muscle. Like if I make it here, this is a normal gut. So what happens? There is a contraction of the proximal gut muscle and relaxation of the distal gut muscles to coordinate that peristaltic reflex that happens. This is further going to make a synapse with the myenteric motor neuron, and again same neurotransmitter they are here also, acetylcholine for the contraction and nitric oxide, that is for the relaxation. But this further makes a synapse with the both dopaminergic neuron, so with the D2 receptor, and it has got the inhibitory influence on the acetylcholine. Once this gets stimulated, it is going to inhibit the release of acetylcholine. So that's all about the vomiting reflex or pathophysiology of the vomiting. Like if I sum up here all that, now what you will be seeing here, there are total, it is going to get the stimulus from the various pathway. Now what are all that? So number one is vestibular nuclei, right? So this is the number one, vestibular nuclei, and number two, that is a CTZ. I'll make here I have written, this is a broader picture of that. Number two is a CTZ, and number three is this brain, and then fourth is a pain, and the fifth one is a GIT, right? Or you can see at different sites I have drawn the receptor also. Like in the vestibular nuclei, you can see the two type of receptor they are there, H1 and M1. What is that H1 stands for? H1 stands for histamine and M1 muscarinic receptor they are there. On the CTZ there are various type of receptor they are there, like 5-HT3 receptor they are there, dopamine receptor is there, opioid mu receptor that is there, neurokinin 1 receptor is there, then cannabinoid receptor, CB1 type cannabinoid receptor, that is also there on the CTZ center. Then coming to here on the vomiting center itself, almost all type of receptor they are there, like histamine, muscarinic, mu receptor, neurokinin, 5-HT3 receptor they are there. On the nucleus tractus solitarius, again we have a histamine receptor, muscarinic receptor, neurokinin and 5-HT3 receptor. Now these receptors, they act as an important target for the antiemetic drug. So drug, they are going to bind with the receptor and they are going to inhibit that emetogenic impulses which is conveyed from this particular site to the vomiting center. So if you want to remember the antiemetic drug, just remember 5 E's. So these five, they are five antagonists like H1 receptor antagonist, M1 receptor antagonist, 5-HT3 receptor antagonist, D2 receptor antagonist, and neurokinin receptor antagonist. Right? Now let's start one by one, each one of them. I will take first M1 receptor antagonist or anticholinergic group of drug. So there's a long list of anticholinergic drug, atropine and its analog. You must have read under the anticholinergic drug. But out of that, a long list, there are the two one, hyoscine and dicyclomine. These are the two which we use as an antiemetic drug. Now they are M1 receptor antagonist. Now where M1 we can see here in this figure, we can see M1 in the vestibular nuclei and we can see M1 in the vomiting center. So they are going to block these here in the vestibular nuclei and right and in the vomiting center. These M1 receptor, they are going to block these two, right? Plus what else they are going to do? They are going to block this emetogenic impulses from the vestibular apparatus to the vomiting center, right? Now vestibular apparatus, when does it get stimulated? Whenever the person feels motion sickness, whenever the person gets rotated or equilibrium that is disturbed. So this group of drug, they are used mainly for vomiting due to motion sickness. Now we have the two drug. What are the basic differences between these two drugs? Both of them, first I will talk about what are the common things these for these two. Both they are used for the uh, as an anti-motion drug for a short journey like 4 to 6 hours. If we are giving a tablet, and both of them they are used prophylactically, means you have to give half an hour to 1 hour before the start of the journey. Once the symptoms set in, then the efficacy of this group of the drug, it decreases. So this is the similarity between these two drugs. Now coming to the differences, I'll take another page of this. Now coming to the differences, like hyoscine, that is available as an oral, IM and transdermal patch. Now this transdermal patch or scopolamine, transdermal patch of scopolamine, it is going to give a protection for 3 days. You have to apply it behind the pinna. 1.5 milligram of the transdermal patch is going to give the protection for 3 days. Now what are the side effects of this group of the drug? The main side effect is it is a sedation. Now what about the anticholinergic? This is an anticholinergic drug. So anticholinergic side effect, they are not seen with this group of the drug because the dose which we use as an antiemetic, that is too less. If you are going to use it for higher dose, then only you are going to what the anticholinergic side effect like dry mouth will be there, then urinary retention, cycloplegic, blurring of the vision, all that will be seen if you are going to give it for a higher doses. Otherwise, the dose which we use as an antiemetic, we can see only the sedation. Now, next group of the drug is antihistaminics. Under this categories, the various drugs which comes are promethazine, diphenhydramine, dimenhydrinate, doxylamine, maclizine, cyclizine and cinnarizine. So now this group of the drug, they are also going to act in the same way. Now you can see the histaminic receptor again on the vestibular nuclei and on the vomiting center, right? Here and here. So they are going to block these directly, plus again the same way, just like an anticholinergic drug, they are also going to block this vestibular impulses from the vestibular apparatus to the vomiting center. And again, this group of the drug, they are also mainly used for the motion sickness. Now coming to the differentiating property among this group of the drug is, we have promethazine, diphenhydramine and dimenhydrinate. Apart from its H1 histamine blocking property, they have other property also, that is they even block M1 receptor. So they have an anticholinergic action, right? Then another one is they have weak antidopaminergic activity, especially this promethazine, right? Then this cinnarizine, they also block the calcium influx from the endolymph into the vestibular sensory cells. So they are going to, which mainly mediate the labyrinth reflexes. So they are going to block that also. Now this group of the drug, they are also used for the motion sickness, because the same pathway H1 receptor, they are involved in the vestibular apparatus. So they are used mainly for the motion sickness, and they are also used prophylactically. And its action is mediated, antiemetic action in the motion sickness is mediated because of the H1. And second one is they are also anticholinergic activity, they have got that also. Now this one is also used prophylactically, and it is going to give a protection again for the short journey, 4 to 6 hours, whereas maclizine, it is for 24 hours for the seasickness. Cinnarizine, this is mainly used as an anti-vertigo drug. Once the vertigo set in, then also this drug, it is effective. Now coming to the next one, this doxylamine and pyridoxine. This combination, it is marketed in our country as a drug fixed dose combination, is marketed as a morning sickness, that is vomiting of early pregnancy, because this is the one which has got to clear the teratogenic potential. Otherwise, usually in a motion sickness, we give a reassurance to the patient, some dietary adjustment. If in case the patient needs a medicine, we can put up the doxylamine and pyridoxine. This combination we prescribe to the patient. Okay. Now next group of antiemetic drug, they are 5-HT3 antagonist. This includes ondansetron, granisetron, palanosatron, ramosetron, dolasetron and propisetron. Now, what is the mechanism of action of this group of drug? They are going to block the action of 5-HT3, as the name itself suggests. Now, where the 5-HT3 receptor, they are involved for the emesis, they are involved both centrally as well as peripherally. So, already I have explained, whenever any GIT irritant, or because of the chemotherapy, because of the radiotherapy or endogenous toxin, poisons, drug, infection, what they do, they are going to cause a release of 5-HT3 from the enterochromaffin cell of the GIT mucosa. And now this 5-HT3, what it is going to do, they are going to carry the emetogenic impulses through the vagus to the vomiting center here by the nucleus Tractus solitarius. Now 5-HT3 receptor antagonists, they are going to block this transmission of this emetogenic transmission of the impulses through vagus to the vomiting center. So this is its peripheral action. Now it also exerts a central action. Central action is 5-HT receptor, they are there in the CTZ center, they are there in the nucleus tractus solitarius, and they are present even on the vomiting center. So they are going to directly inhibit the 5-HT3 receptor at this particular site. Now where we are going to use this group of drug? This group of drug, mainly they are used for the chemotherapy induced nausea and vomiting and radiation induced nausea and vomiting. So whenever we are giving chemotherapy, with the chemotherapy there are two phases of nausea and vomiting. One is acute phase, especially if you are giving the highly emetogenic chemotherapy. If you are putting highly emetogenic chemotherapy to the patient, you can see two phases, acute, and second one is a delayed phase. Acute phase, that happens within 24 hours, whereas delayed phase, that happens on the 2nd to 5th day. Now this group of drug, they show effect only against this acute phase of nausea and vomiting, not against the delayed phase. Even if you are giving a combination of this with the dexamethasone, ondansetron with the dexamethasone, it is not showing any response against this except one 5-HT3 antagonist that is there, which is going to show the effect against this, that is palanosatron. Because this has got the longest half-life of 40 hours. And another group of drug which shows the effect against this, that is neurokinin receptor antagonist, aprepitant, fosaprepitant, natripitant, they are the drug which comes under this category. So there is a combination of natripitant and palanosatron, FDC approved combination, which is used against this delayed phase of nausea and vomiting due to highly emetogenic chemotherapy. Number 2, where else we can use it? That is for the post-operative nausea and vomiting. So in post-operative nausea and vomiting, they are highly efficacious and even side effects, they are very less. So these days they are considered the first choice of drug against for the post-operative nausea and vomiting. For the drug overdose, there also we can use it. Then for the GIT disorders like uremia, there also we can use it. And in certain condition of hyperemesis gravidarum, where we cannot avoid that condition, there also we can put the patient on 5-HT3 antagonist, but still the safety profile of this 5-HT3 antagonist for the pregnancy, it is not available. So these are the few uses of this 5-HT3 antagonist. Now where we cannot, hyperemesis gravidarum, now where we cannot use it, a big no-no, in the motion sickness, because you can see the H1 and M1 receptor, they were not involved here, and apomorphine induced nausea and vomiting, there also they are not used. There are the few individual differences among these group of drug, they are there. I'll just explain. Ondansetron, like this one is the shortest acting, right? Palanosatron, that is the longest acting. Half-life here it is 3 to 6 hours. Granisetron 8 to 12 hours. This is 40 hours. This has got highest affinity, palanosatron, in how they are metabolized. One important thing is this group of drug, they are hydroxylated with 1A6, 2D6 and 3A4. Where these comes, that means some drug interaction with the enzyme inducer and inhibitor, they are seen. Ondansetron does not show any drug interaction, whereas planosetron that shows the drug interaction. So this group of drug, it shows the drug interaction that is there with this. So QT prolongation that is seen if you are going to give it with the enzyme inhibitor like erythromycin. So should not be combined with other drug which shows the QT prolongation. So next group of drug is NK1 receptor antagonist. So under this comes aprepitant. We have fosaprepitant, natripitant and rolapitant. Fosaprepitant, that is a prodrug of aprepitant, which is given by IV route. Now what is the mechanism of action of this group of drug? Due to emetogenic chemotherapy, the substance P that is released, that substance P, it is going to act on the neurokinin receptor which is present on the CTZ center here and which is present on the nucleus tractus solitarius. Now these two ultimately they are going to stimulate vomiting center and vomiting that is induced. Now this group of drug, they are going to block these neurokinin receptor or tachykinin type of receptor, and by that they are going to reduce the vomiting which is produced because of the release of substance P, and that is released because of the emetogenic chemotherapy. So now where we can use this group of drug. So uses are again chemotherapy induced nausea and vomiting. Here it is mainly used for the delayed phase of chemotherapy induced nausea and vomiting, especially if the person is taking multiple cycles of chemotherapy, there it is useful. Then it can be used as a adjuvant, so increases the efficacy of other antiemetic drug, like already I have told you, the natripitant is given along with planosetron. So fixed dose combination of these two, they are available. This is 300 milligram and 0.5 milligram, that is available. Now this drug, it can be usually given like aprepitant is given along with ondansetron and dexamethasone. So it can take care of delayed phase of chemotherapy induced nausea and vomiting, especially even with a highly emetogenic drug, that is with a cisplatin. Then another indication of this one is a single dose of aprepitant is as effective as ondansetron for the post-operative nausea and vomiting. Other important features of this group of drug is we can aprepitant especially, so we give it by oral route. It is metabolized by 3A4, so enzyme inducer and inhibitor. It shows the important drug interaction and especially the QT prolongation, so should not be given along with the drug which is going to cause the QT prolongation, excreted in bile, in feces and then in the urine also. So this is about the NK1 receptor antagonist. Now the next group of drug is that is dopamine or D2 antagonist, also called a neuroleptic or antipsychotic drug. Here chlorpromazine, that is mainly used as an antipsychotic drug, even triflupromazine, that is also antipsychotic drug, and then prochlorperazine, metoclopramide and domperidone. All these, they are D2 receptor antagonists. Their antiemetic effect is because of by blocking the D2 receptor on the CTZ center. They act by blocking this receptor. Along with that, they have got the additional receptor blocking property, like they block even M1 receptor, they block even H1 receptor. Now out of these, this metoclopramide and domperidone, this I will be discussing in my next video along with the prokinetic drug. Coming to this one, now this group of drug, where it is used. It is mainly act by blocking the D2 receptor. So it is used for the drug-induced nausea and vomiting, then post-operative nausea and vomiting, and very weak action against the chemotherapy-induced nausea and vomiting, radiation-induced nausea and vomiting. Then for the motion sickness, this prochlorperazine, this is also used as an anti-vertigo drug, very commonly the trade name that is Stametil. It is available in the market. So this is given by that. And then it is also used for the morning sickness, that too in hyperemesis gravidarum. And again, if it is unavoidable, then only we can give, otherwise there is no safety data that is available even for this group of drug. Now, what are the important side effects with this group of drug? They are going to act by blocking the D2 receptor. So by D2 receptor, that means some extrapyramidal side effect will be seen. The most important here is muscle dystonia, that is seen especially in the children, because the dose which we are using as an antiemetic, that is too less. So one or two extrapyramidal side effect, acute muscle dystonia, that is only seen, and then another is a sedation. Now the next antiemetic drug, that is a cannabinoid receptor agonist. So this is the agonist. Now finished the 5 antagonistic drug. Here the drugs are dronabinol and nabilon. They act by blocking the cannabinoid receptor on the CTZ center and cannabinoid receptor on the vomiting center itself. Now where they are used? They are also used against the cancer chemotherapy induced vomiting when the person is not showing response to any other drug. What are the side effects with this drug? There are the few limitations with this drug. It is going to cause a disorientation, then hallucination, then CNS sympathomimetic effect. The person feel very high, experience high. This has got the addiction liability. Because of that, it is not used in routine. Only if the person is not showing response to any other antiemetic drug, then only we are going to put the patient on this group of drug. It is also appetite stimulant. That is another use of this cannabinoid receptor agonist. Now the next group of drug is adjuvant antiemetic, like dexamethasone. Already I have shown you the with the aprepitant on ensatron dexamethasone, that is given for both acute phase as well as for the delayed phase of the emesis due to cancer chemotherapy. And the main mechanism is, maybe it has exerts the anti-inflammatory. Benzodiazepine, it is going to take care of the psychogenic component of the emesis. So these two, they are adjuvant antiemetics. That's all about the antiemetic chapter. So now coming to the clinical classification of the antiemetic. So 5 A's and 1 agonistic drug with the adjuvant drug. Now in the beginning only I told you what kind of question you will be getting under the antiemetic drug, like drug for the motion sickness. For the motion sickness, it is the vestibular component that is involved. So the two type of receptor they are present, H1 and M1. So we will be giving muscarinic receptor antagonist and histaminic receptor antagonist. Then for the morning sickness, this is a combination of doxylamine and pyridoxine. For the chemotherapy and radiation-induced nausea and vomiting, we have 5-HT3 antagonist and neurokinin receptor antagonist. Along with that, we give the adjuvant drug like dexamethasone, that is also given along with this. Then for the post-operative nausea and vomiting, again 5-HT3 receptor antagonist, then neurokinin receptor antagonist, and even D2 receptor antagonist. Now, few of the important MCQs. Which of the following 5-HT receptor that play important role in causing emesis? So far we have read it is 5-HT3. Now the second one is, a person has to go to Shimla next morning. What drug should be given to prevent the motion sickness in this person? The first choice is scopolamine patch night before. The second one is ranitidine one night before and then before the trip. And the third one is diamine hydronate 1 hour before the journey. and the fourth choice is omeprazole half an hour before the trip. So here the right choice is it is a hyoscine or scopolamine patch before the one night before the journey. Ranitidine, it is H2 receptor blocker. This one is also H1 receptor blocker, but here the main drug which we are going to prescribe, that is anticholinergic drug. Omeprazole, that is proton pump inhibitor. Now the next question is drug used in cancer chemotherapy induced vomiting is ondansetron, cisapride, metoclopramide and triflupromazine. Ondansetron, so cancer chemotherapy, you know it is a with the chemotherapy 5-HT3 that is released from the intestine, which is going to stimulate that vagus nerve, and through the vagus it is going to stimulate the vomiting center via the nucleus tractus solitarius, and even this has got the peripheral stimulation of the vomiting center. Even on the directly it is going to stimulate the CTZ center and the vomiting center itself. So we are going to give the 5-HT3 antagonist, which is a ondansetron. Cisapride, this is a prokinetic drug. Metoclopramide, that is D2 receptor antagonist, and triflupromazine, that is also a D2 receptor antagonist. So next is which drug is given in delayed vomiting after chemotherapy. So in delayed vomiting, so in early vomiting 5-HT3 that is effective. So in delayed vomiting it is a neurokinin 1 receptor antagonist. So correct choice is it is aprepitant. So that's all about the antiemetic topic. So see you in my next video with the prokinetic drug.